Okay, everyone. Today we're going to be talking about medications affecting protection, specifically antibiotics. So we unfortunately have many bacteria that are resistant to a lot of our antibiotics. And this has come about from a variety of reasons. One is the administration of antibiotics for a viral infection. As you know, antibiotics don't treat viruses. People would, years ago would get the sniffles and they would just go to their doctor and expect an antibiotic be prescribed. Or doing it when an infection isn't present. Not all inflammation is the result of an infection. We know that. So people would feel like, a sore throat that maybe had something to do with the dry air in their room. They think they have something more sinister. They would go to their doctor and expect an antibiotic. So we don't do that anymore. If we have a confirmed case of the flu, we don't give them an antibiotic. And years ago, people would basically go and demand, absolutely, I'm sick, I need an antibiotic. Well, if you don't have a bacterial infection, it's pointless and it leads to resistant organisms. And then the other part is people incorrectly taking antibiotics. So skipping a dose or not taking the full antibiotic regimen. They feel better at day 5, and so they stop taking it altogether. And then whatever bacteria are still alive, because they were sort of immune to it in the first place, those are the only ones left, and those are the ones that proliferate, the ones that had a natural resistance in the first place. So misuse and resistance is a huge problem. We're getting to the point where there are fewer and fewer antibiotics that don't have resistant organisms. One thing that can also occur is if the chemical structure of the antibiotic is similar to another and a bacteria becomes resistant, they can become resistant to multiple antibiotics in the same class because they have the same chemical structure. So that's what cross resistance is. So it can occur between antibacterial drugs with similar actions or similar chemical structures. So one thing we do is a culture and sensitivity. So a culture is we take a swab, sputum, or a blood sample, and then we grow a section of that in a petri dish or in a special bottle, and we grow a multitude of, just so we can see what the agent is. That's what a culture is. And then we do a sensitivity test. We want to see what antibiotics will kill this organism. So not every antibiotic kills every organism, so they will, and we want to see if something's resistant, so we will do a sensitivity test. Okay. Sometimes we also do multi-antibiotic therapy, which is the daily use of several antibacterial, and that delays the development of microorganisms. So you'll see patients with, a specific bacterial infection that will be on 2 or sometimes 3 different antibiotics, and that's done by design. So we have narrow spectrum, so primarily effective against one type of bacteria. And things like penicillin are very narrow spectrum. And then we have broad spectrum, which are effective against multiple gram-positive and gram-negative organisms. And things like tetracycline would fall into that category. And sometimes we start with a broad spectrum agent. We have someone that comes in with an overwhelming infection. They're showing signs of an inflammatory response systemically. Maybe a drop in blood pressure. We don't have the luxury of time of waiting for the cultures to come back and then a sensitivity test to see which agent is going to work. We need to fix them now. So we will oftentimes give them broad spectrum and more than one agent, in fact, so maybe Zosyn and vancomycin, for example, until we have the cultures and sensitivities back. We would always culture the patient before starting antibiotic therapy. Always remember that. We want to make sure that we've cultured and figured out what the organism is before we start any antibiotic treatment. How do antibiotics work? I want you to just understand that different antibiotics affect the cell in very different ways, right? So for instance, penicillins have part of their chemical structure is called a beta-lactam ring. And that's just part of the chemical structure of a penicillin. And what that does is it affects the cell wall of the bacteria. And once you destroy the wall, you kill its bactericidal. It inhibits cell wall formation, right? the polymyxins, so colistin, disrupts the cell membrane. So not every antibiotic works the same way. We also have things that are bactericidal and bacteriostatic, meaning cidal means it actually kills the cell. And static, bacteriostatic, means that it doesn't exactly kill the bacteria, but it doesn't let it proliferate. And while we're stopping it from growing, our own immune system can step in and kill it. All right, so the big ones that I'm sure all of you have heard of or at least taken are the penicillins. And those are bactericidal, meaning they inhibit cell wall formation. And the reason it works on the bacteria and not us is humans don't have cell walls. We just have cell membranes. So many organisms, unfortunately, this is being one of the older agents. This has been out since now the late 40s. Well, it was around in World War II too, I believe. But it's been around a long time. So many organisms have developed resistance. And what the bacteria do is they make something called beta-lactamase, which actually is a chemical that goes and destroys the beta-lactam ring. So the thing that affects the cell wall, well, the bacteria come up with their own defense, and they send out their own chemical warfare, and that kills the penicillin. Not kill, but, neutralizes the penicillin. So I have a picture of structure so you can see what I'm talking about with the beta-lactam ring. That's that section in the middle with the oxygen molecule on the outside of it. All right, so penicillin G, injection is preferred for that. And that's used for group B strep. So we use that for our labor patients a lot. It's also used for lower respiratory infections. And then we have Pen V, which is oral, and that's for upper respiratory infections, strep throat, things like that. Then we have combination product, the ampicillin and sulbactam, which is called Unicin, and that's a little more broad spectrum. And the sulbactam, what that does is it inhibits beta-lactamase. So the beta-lactamase that the bacteria sends out as a defense? Well, the sulbactam inhibits that so that the ampicillin can actually do its original job. It's also used for group B strep and labor patients. It's used for pneumonia, skin infections, chorioamnionitis, gonorrhea. Then we have amoxicillin by itself, and then we have augmentin, which is amoxicillin, and the I can never say this word, clavulinate. And the clavulinate is the inhibits beta-lactamase. Again, so it's that extra additive so that we're limiting the bacteria's ability to defend itself, and amoxicillin can then do its job. That's used a lot for ear infections, skin infections, and UTIs. Well, it's probably the most commonly prescribed medication to kids. It's used in that population for almost exclusively for otitis media. Then we have cephalosporins, which also is bactericidal by inhibiting the cell wall, just like penicillins. They're very similar in structure to penicillin, but are naturally beta-lactamase resistant. Unfortunately, it's close enough. It's a close enough cousin that there's a lot of cross allergies to penicillin. So a lot of people who are penicillin allergic, if they're prescribed a cephalosporin, we need to be very careful and watch them for an allergy. It does happen quite a lot. And even though the cephalosporins are naturally beta-lactamase resistant, it doesn't eliminate bacterial resistance. Okay? So we have generations of cephalosporins. You'll see that the first group that came out were the first generation and second and so forth. And they're most often used for respiratory, urinary, and skin infections. Okay? So Keflex, which cephalexin, which is a first generation, skin, bone, otitis media, respiratory, UTIs. Then we have the Cefdinair, which is a third generation that's used for otitis media, sinusitis, tonsillitis. You can read the slide too. Some of the doses between the key text and the McQueestian text, the doses are slightly different. I am aware of this difference, and I'm keeping that in mind when I write your test questions. Just know what the class of medication, a general dose range, and what it's used for, okay? And then we have cefepime, which is a fourth generation, and this is a heavy-duty one. It's mostly resistant to beta-lactamase and used for severe infections. This is, I used to use this a lot in the ICU, things like pneumonia, and if you have a E. coli that is resistant, like a really bad UTI, then sometimes they get cefepime. Then we have the macrolides. In higher doses, they're bactericidal, and at lower doses, they're bacteriostatic. They act in the ribosomes of the organisms by inhibiting protein synthesis, right? These are metabolized by the liver and excreted in bile, a little bit in urine too. So you have to be very careful in patients with impaired liver or kidney disease. All right, so just be careful, especially with the liver disease. So erythromycin ethylsuccinate, or EES, you'll often see it abbreviated by the physician as EES. It's used for things like acute pelvic inflammatory disease, chlamydia, pneumonia, and some other respiratory infections, especially if they're penicillin allergic. So for some kids, with strep throat, they would get this if they were allergic to penicillin. All right. The ethylsuccinate helps prevent the med from being destroyed in the gastrointestinal tract, so it can be taken PO. Then a very common med that a lot of adults have heard of is Zithromax or azithromycin, the quote-unquote Z-Pak. This is used mostly for penicillin, pneumonia, so respiratory infections, skin and soft tissue as well, and it's often used if allergic. The reason the Zithromax or the Z-Pak is a very popular formula is that it has an extremely long half-life of 68 hours. So dosing is over 3 to 5 days. So if even with 3 pills, 3 days in a row, it lasts for over a week. So it's very popular, and it limits resistance, because if you only have to take 3 pills 3 days in a row, guess what? You're more likely to take the pills. People are more likely to remember something for a short period of time. But you don't take this. It does need that needs your gastric pH to stay acidic, to be absorbed. So you don't want to take this at the same time as you would take an antacid. All right. So tetracyclines. These are bacteriostatic or bactericidal, and again, they also inhibit protein synthesis. The most common one is we try to avoid tetracyclines in little kids because it can cause severe discoloration of their teeth, and including their adult teeth. Photosensitivity, meaning light sensitivity, and nephrotoxicity, so kidney impairment. So we want to avoid tetracyclines in pregnancy because it is teratogenic, and avoid it in children less than 8 for that severe teeth problems. And so for tetracycline, this is one of those ones we use a lot for chlamydia and gonorrhea. And it's sometimes used as the ophthalmic ointment. Instead of erythromycin, sometimes it's a tetracycline instead, as part of that eyes and thighs. So in some places, instead of erythromycin, they use tetracycline ophthalmic ointment instead. Or if we have a high-risk population, a child that's, at high risk for this. It's also used for respiratory infections, skin, acute pelvic inflammatory disease, and sometimes used to treat H. pylori, which, as we know, is a leading cause of gastric ulcers. The other med in this class is doxycycline, and this one's big up here because it's one of the few that really kills Lyme disease. So if you're over the age of 8 and you weigh more than 45 kilograms, they will use this to treat Lyme disease. It's also used for respiratory and skin infections, and can also be used for chlamydia and gonorrhea. So if we would do this with an additional dose of IV cephalosporin, and it also kills syphilis, so kills all the STIs. Fluoroquinolone is sometimes also just called a quinolone. Those are bactericidal, and they inhibit DNA gyrase, which is needed for DNA coiling. Okay, so those are used to treat UTIs, lower respiratory, skin and soft tissue, bone and joint infections. So the big one in this class, and the exemplar we're using, is ciprofloxacin, which is Cipro. Most women have heard about this one. It's used commonly to treat UTIs. Also, it's used for respiratory infection and can be used as otic drops for otitis media and otitis externa. So it can be used as an ear drop for an ear infection. It can also treat bone and joint infections. Sorry. Okay. Sulfonamides, they're not technically an antibiotic because they were derived from coal tar. They're bacteriostatic, so they inhibit cell synthesis of folic acid. Okay, so we don't make our own folic acid. We require that through what we take in our food. So that's why it only affects the bacteria. It's very useful in E. coli, and so it's used for treating like mild UTIs or for UTI prophylaxis in prone patients, like for people who have like chronic urinary retention and have chronic infections, or people who have an indwelling catheter. You have to be careful. These can crystallize in urine, so you're going to watch their urine function. So the common one here is the trimethoprim sulfamethoxazole or Bactrim. So Bactrim's a really common UTI medication. UTIs, which is why it's in bold. It's almost exclusively given for that, though it can be administered for some respiratory infections. But we have much better agents for that. The lincosamides, those are bactericidal in higher doses, bacteriostatic at low, and those act in the ribosomes of organisms by inhibiting protein synthesis. So the one we're talking about is clindamycin. This is used for serious infections, okay? Endometritis and chorioamnionitis, so infections of the uterus commonly. And it's often used for dental infections. So if you had an impacted tooth that got infected and now you have an abscess in your mouth, clindamycin is usually what the dentist would prescribe. This med is highly associated with later development of C. diff superinfection. So this is one of those agents that when you see a patient getting this, you should be having a serious talk to them. We would teach every patient about the risk for C. diff, but if they are in clindamycin, they need to have a really, you need to tell them that if they develop any diarrhea, they need to tell their provider about that because they are at risk for developing C. diff. Aminoglycosides are bactericidal, and those also inhibit protein synthesis, and they're used for really serious infections. They cannot be absorbed through the GI tract and are given IM or IV. They cause nephrotoxicity and ototoxicity. Okay, so gentamicin sulfate, see my little guy at the bottom, he's supposed to be my mycin mouse, and he's shaped like a kidney with big ears. Okay, so to remind you that they are nephrotoxic and ototoxic, meaning use of gentamicin in neonates can cause deafness, okay? And they can cause serious kidney failure, all right? You can't take these by pill. Remember that, IM or IV. Okay, they're used for serious gram-negative infections like Pseudomonas, all right? MRSA, suspected sepsis, pelvic inflammatory disease. All right, so we're using them. This is a big gun. All right, and because it can cause nephrotoxicity, we need to check peak and/or troughs. What is that? Well, we're going to draw after usually the third or fourth dose, or before the third or fourth dose. They're going to draw a blood level and see what level, how much is still swimming around, how much free drug is still available, and they may make a dose adjustment because of that. And now I have my glycopeptide. So I have vancomycin. Oh, my mycin mouse is back. Now remember, not every med that ends in mycin is nephrotoxic. Okay, my gentamicin and my vancomycin are the two that I really have my mycin mouse out for. Okay. So they can cause severe nephrotoxicity and ototoxicity. More nephrotoxicity with vanco. Okay. This is one of the biggest guns we have. We use it for MRSA. We use it for serious infections like sepsis. It's usually part of the quote-unquote septic cocktail. Nowadays, we're using more vancomycin and something like piperacillin or the Zosyn, like really serious infections. This one has peaks and troughs. Again, it's a pregnancy category C, so we use it when we have to. This one, the trough level is what I'm sorry. Yes, we use a trough. But in some places they use a peak. So what a trough is before the dose is due, about an hour before the next dose is due, they draw a serum level. And for vancomycin, the trough level is between 10 and 20 is considered therapeutic. So if it's below 10, then they increase the dose. If it's over 20, they decrease the dose or they decrease the frequency. Okay? Common thing here is red neck or red man syndrome. So you can have like red blotching on their face, neck, chest, and extremities. It's a toxic reaction, not an allergic reaction. So to avoid that, we give this over a couple of hours. So we used to throw it in over an hour, and then we started seeing red neck or red man syndrome. So now you'll see an order when you give vancomycin, it gets administered sometimes 2 to 3 hours for each dose. All right. It is not absorbed through the GI tract, but sometimes it is given orally or rectally to kill off C. diff. Because remember, we're trying to kill an organism in the GI tract itself. It's not going to get absorbed systemically, but if we want to kill a bacteria that's sitting in the gut, we may give it orally or rectally because we're directly, going to kill the C. diff itself. All right, so you may see vanco enemas, or you may see PO vanco, and that's not going to kill an infection in your bone or anything because it doesn't get absorbed through the GI tract, but it will kill C. diff. All right, now we have peptides and metronidazole. So peptides, we think, interfere with bacterial cell membrane function. And metronidazole impairs DNA function of susceptible bacteria. So the first one is the peptide, and that's bacitracin, right? We've all seen it. It's in all kinds of over-the-counter stuff. It's a topical agent used for skin and eye infections and for infection prevention. So you get a boo-boo on your finger, you're going to throw some bacitracin on there, and somehow it works, okay? And then we have metronidazole, which is Flagyl. These are used for, metronidazole is used for serious gram-negative infections like UTIs or septicemia, Pseudomonas, or when other antibiotics are ineffective. And this can include severe GI discomfort, all right? Sometimes they give it prophylactically before colorectal surgery. So you're going to have part of your colon removed. They may give you Flagyl. It's also used to treat Clostridium difficile or C. diff. And it may also be used with H. pylori to treat H. pylori with other agents. All right, so Flagyl is a very common medication nowadays. All right, so common antibiotic therapy for respiratory infection. So otitis externa or swimmer's ear, they may do the Cipro drops, Cipro HC Otic. They may do something called Ciprodex, which is ciprofloxacin or Cipro with dexamethasone. So otitis externa is just the external part of the ear is sore and infected. So it's not all the way in the middle ear. It's in the outer part of the ear. Otitis media or middle ear infection, sinusitis, or strep throat. So they may do Pen-V or erythromycin if they're penicillin allergic. They can do amoxicillin in higher doses. They may do Augmentin, remember, which is the amoxicillin with the something that inhibits that beta-lactamase. Keflex or a Z-Pak, azithromycin. And then for pertussis or whooping cough, which is more prevalent in Rhode Island than ever before, they may use erythromycin or a Z-Pak, azithromycin. Okay, so common skin and tick-borne infections. So impetigo, also called the creeping crud, is one of the most common and contagious skin infections in children, and that's a staph infection, which is more and more penicillin resistant these days. So most of the time we use a topical solution like mupirocin. I didn't include the other oral agents in there. I just took them out. Most likely it's just mupirocin. Lyme disease, which is up here in the Northeast, that's our claim to fame. Antibiotic therapy usually takes at least several weeks, if not months, to cure. So for a little kid, unfortunately, they get stuck using amoxicillin or Augmentin. because they're too young to have the doxycycline. And if they're 8 years old and weigh more than 45 kilograms, they can use doxycycline, which is a much better agent. But this little bugger, this spirochete, takes several months to cure, so they're on long-term antibiotic therapy for that. So common antibiotic therapy for urinary tract infections. So first-time infection, they may go with the Bactrim, the trimethoprim, sulfamethoxazole. Or repeated infections, ciprofloxacin, the Cipro. Systemic, if they have severe pyelonephritis, so we have a urinary tract infection that moved on up into the kidneys, we may see initially an IV cephalosporin or another med in the penicillin family until they get that under control, and then they would switch them to another agent. Common treatment for sexually transmitted infections. So chlamydia, we use azithromycin or doxycycline, and for gonorrhea, we can use azithromycin or doxycycline plus 1 dose of an IV cephalosporin. And we must treat sexual partners to prevent reinfection. It's very common to have the same person come in over and over again with the same infection because the partner was not treated. So both partners, or if there's multiple partners, all the partners need to be treated to prevent reinfection. Okay, so general adverse reactions to antibiotic therapy. A mild allergic reaction would include a rash or pruritus or hives, itch. Severe allergy includes anaphylaxis, which we know includes bronchospasm, laryngeal edema, vascular collapse, cardiac arrest. Treatment is an antihistamine. If they're having anaphylaxis, they're going to get epinephrine and a bronchodilator. Be very careful if you're using meds in the same class if there's an allergy. So if you have a patient who's allergic to doxycycline, you would be very, very careful before you gave them tetracycline, okay? And remember, the most common ones are penicillin and one of the cephalosporins. There is often a cross-sensitivity to penicillin and cephalosporins. Not always, but sometimes. Super infections. So when we kill off the normal flora, then we would get a secondary infection based like C. diff. We can also get yeast infections or thrush. So mouth, skin, respiratory tract, vagina. For the yeast infections or thrush, those can happen anywhere there we have a skin fold. It isn't just the vagina. You can get it under the breast. You can get it in the groin. And we know that the samples of the symptoms of C. diff are that severe diarrhea. Organ toxicity, ear, liver, or kidney. GI upset. Even when there's no superinfection, many patients report abdominal discomfort and loose stools from antibiotics. We're usually killing at least part of the gut flora. So, deadly diarrhea, C. difficile, causes immense suffering and death. This is a bad bug. It's especially problematic because what it does is it makes spores, and the spores are kind of inactive small versions of itself that are virtually impossible to kill, and they just hang out and they wait for the environment to become conducive to growth. So when you have an antibiotic such as clindamycin and it kills off a huge chunk of your bacteria in your gut, the environment becomes conducive to growth of C. diff, and that happens a lot. So caused close to 500,000 illnesses in 1 year. Whew. And it comes back at least once in 1 out of 5 patients who get it, so it can recur. And 1 in 11 people 65 and older died within a month of the infection. It is huge. All right. Antibiotics are 7 times more likely. People who use antibiotics, okay? And it's really common in our healthcare industry, all right? More than 80% of C. difficile deaths occurred in people aged 65 and older. So for mild or moderate disease, you would get oral flagyl, the oral metronidazole. 500 milligrams 3 times a day for 10 days is getting this on board right away. So you have an antibiotic use and patient is reporting diarrhea, getting them right on the right agent to kill this is really, really important. So nursing interventions for antibiotics. We want to check the culture and sensitivity before our drugs are given, or at least we have to make sure that cultures have been done before the first dose of antibiotics. With any antibiotic, we have to monitor closely for an allergic reaction. We're going to report all rashes to the provider. Stevens-Johnson syndrome can be caused by antibiotics. We want to promote fluid intake, avoid caffeine and alcohol. All right. Women using hormonal contraception should use a backup method while using antibiotics. We can have an accidental ovulation. Antacids can affect the absorption. GI upset is common for most antibiotics, but we want to tell people not to take the antacid at the same time they're taking their dose. We want to monitor them for superinfection like C. diff. We want to review labs. And a lot of these are hard on the liver or the kidneys, so you want to make sure that you're making sure that those functions are normal, and if they're not, that the dose is amended accordingly. And some of these drugs can cause blood dyscrasias like anemia. All right. For drugs causing photosensitivity, patients should be advised to stay out of the sun or to wear a hat or sunscreen. And I put, actually everyone should be advised to wear sunscreen, but for a photosensitive medication, they really need to stay out of the sun because they're going to burn. All right. So a patient has been prescribed trimethoprim sulfamexazole or Bactrim. The nurse realizes that this drug is most likely used to treat which condition? What are we thinking? Urinary tract infection. This is most commonly given for a UTI.